The following presentation is part of a certified educational activity provided by Medscape Education and supported by educational grants from Amgen, AstraZeneca, Daiichi Sankyo, and Novocure. Hello, I'm Dr. Felip Liu, Director of Thoracic Oncology at Georgetown Lombardi Comprehensive Cancer Center in Washington, D.C. Welcome to this program entitled Expert Insights on the Management of Lung Cancer, a podcast series. I have the distinct privilege of being joined today by Dr. Enriqueta Felip, head of the Thoracic Oncology Unit at the University Hospital Vall d'Hebron in Barcelona, Spain. Thank you for joining us, Enriqueta.
Thank you, Stephen.
The topic of today's podcast is What's New in HER2, Evaluating the Evidence in Non-Small Cell Lung Cancer. And, over the past decade, we've made remarkable progress in the treatment of non-small cell lung cancer. And one of the major reasons is our understanding that non-small cell lung cancer is made up of many biologically distinct cancers. And as we start to recognize these different subsets and their different biology, we can start to treat them differently. I think it largely began for lung cancer with EGFR mutations, which lead to a very specific type of lung cancer with its own behavior, its own vulnerabilities. And by implementing therapy targeting that vulnerability, we have seen remarkable responses. EGFR and ALK were two of the first, but we now have many relevant targets. And one of the newer ones is HER2. HER2, or ERB-B2, is a target that in oncology we're very familiar with, but typically in a different context. We think of HER2 and immediately we think of breast cancer. More recently, we think of gastric cancer. But let's start by talking about terminology. Enriqueta, HER2 is now relevant in lung cancer, but the HER2 alterations we're interested in for non-small cell lung cancer are quite different from what we look at in breast cancer, right?
Yes, Stephen. So HER2 is at present a relevant target in lung adenocarcinoma, but in lung adenocarcinoma, we have three different HER2 activating mechanisms described. We have overexpression, immunohistochemistry positivity, 2+ or 3+, in 25% of the cases. We have also amplification in 2 to 3% of the cases, but the important mechanism of activation is mutations. We know that HER2 mutations are present in approximately 3% of lung adenocarcinomas. We know that these mutations are usually exclusive of other known oncogenic drivers such as EGFR, ALK, ROS, BRAF, KRAS. And also we know that these mutations are more common in women and never smokers. So in lung cancer, compared with HER2 amplification or overexpression, HER2 mutations are emerging as the most clear targetable driver for HER2-directed therapies in lung cancer. So it's quite different of what we have seen in breast cancer, and important for non-small cell lung cancer is to test for HER2 mutations.
It's important we get those straight. So very good point. Mutation, not amplification, is what we're immediately interested in for lung cancer. But it's not just the alteration that's different. The agents of interest are different too. And trastuzumab was a very important agent for HER2-positive breast cancer, but it doesn't really play a role in lung cancer. Some of the newer agents do overlap. So let's talk about some of the relevant HER2 agents for non-small cell lung cancer. TDM1, trastuzumab emtansine, is an antibody drug conjugate that has shown some activity. Can you review that drug a little bit for us, Enriqueta?
Yes. So antibody drug conjugates are emerging anti-tumor agents in oncology. And we have these two agents, TDM1 and trastuzumab deruxtecan, being analyzed in patients with lung cancer and HER2 mutations. TDM1 was analyzed as monotherapy in patients with HER2-positive lung cancer, defined as immunohistochemistry 3+ or immunohistochemistry 2+ plus positive FISH or HER2 mutation. And this study was terminated early because of low efficacy at the interim analysis. But there is one study of including 18 patients with metastatic HER2 mutations and lung adenocarcinoma, and the treatment with TDM1 was associated with a response rate of 44% and a median progression-free survival of 5 months. Trastuzumab deruxtecan is a novel HER2 targeting ADC with very nice results in HER2 mutant lung cancer patients. We have the prospective phase 2 Destiny Lung 01 trial including 90 patients with lung cancer and HER2 mutations previously treated with chemotherapy. And in this study, trastuzumab deruxtecan was associated with a response rate of 55% and a median duration of response of 9 months, median progression-free survival of 8.2 months, and median overall survival of 18 months. Very interesting results in this patient population. When we analyze toxicity, we have seen that grade 3 or higher drug-related adverse events occur in 46% of the patients, the most common event being neutropenia. And drug-related interstitial lung disease occurred in 25% of the patients and resulted in death in 2 patients, 2.2% of the cases. So in general, very nice results with trastuzumab deruxtecan in this group of patients with lung cancer and HER2 mutations previously treated with chemotherapy.
And both of these antibody-drug conjugates clearly active. They are not yet FDA approved. They are listed in our NCCN guidelines. In my own clinic, I found that TDM1, a very well-tolerated drug. I've had very good experience with it. Resistance is something that we do encounter, and I think we're still kind of learning about that. TDXD, trastuzumab deruxtecan, a little bit newer. The toxicity profile, maybe a little more adverse events, I think, than TDM1, but also a higher reported response rate. And the durability of these responses, I find, is pretty impressive. And okay, you were involved in generating these data with the trastuzumab deruxtecan, with the TDXD. Has your experience in practice been similar to what we see in the manuscript?
Yes, I don't have experience with TDM1. This is the reality, but I have participated in the study analyzing trastuzumab deruxtecan. I have a very good experience with the Asian. So tolerance, it's true that the patients have some kind of neutropenia, but is well tolerated without symptoms. And I have some patients with long-term benefit of this agent. So my experience is very similar of what the manuscript is summarizing.
Yeah, the durability is impressive. The neutropenia is something I did notice, and I am using growth factor selectively in some patients. The one we talk about a lot is pneumonitis. And I think we're still trying to figure out if there are predictive markers for that. Do you do anything special for the pneumonitis, or just kind of keep it in the back of your mind if patients develop symptoms?
Yeah, I think we need to know that this is a potential adverse event, but also we need to work a lot of diagnosis of pneumonitis, because in patients with lung cancer, there are other potential diagnoses with lung issues. So I have no any case of interstitial lung disease in my experience, but it's true that we need to work on that and also to learn of what happened in other tumor types, such breast or gastric cancer.
Yeah, we've seen some guidance from our colleagues in breast oncology, and I, like you, haven't had any experience with pneumonitis yet, so hopefully that'll continue. These are both exciting drugs, these antibody-drug conjugates. There's a different strategy, sort of on the opposite side of the cell membrane, really looking at small molecules or kinase inhibitors. And there are some challenges with that, but poziotinib is an oral agent that does have fast-track designation for HER2 mutant lung cancer by the FDA. Can you tell us a little bit about that agent?
Yeah, so poziotinib, as you mentioned, is a irreversible covalent TKI analyzed also in patients with HER2 mutations. There is one study involving 90 patients with HER2 mutations previously treated with chemotherapy and that received poziotinib, and we observe a response rate of 28% and a median progression-free survival of 5.5 months. In general, with poziotinib, the most common adverse events of grade 3 or higher were rash, diarrhea, and stomatitis. And there is also one presentation of using poziotinib in patients with HER2 mutant non-small cell lung cancer treated first line with this agent, with a response rate of 43% and PFS of approximately 6 months. So also interesting results in this scenario.
I also just want to note that we've been able to do these studies pretty successfully, sort of globally. When we look at the TDM1 data, that made it to the NCCN guidelines with, as you said, just 18 patients. But now we're seeing studies with 90 plus patients, multiple trials, and so we can collectively do these studies for less common alterations. I think the kinase inhibitors, we do have to worry about that therapeutic window, about the wild type EGFR inhibition and toxicity, and really requires sort of aggressive dose management, aggressive management of toxicities, anticipating those. But always good to have multiple agents. I think we probably expect the resistance to these drugs to be different. So there may be a role for multiple agents, multiple lines of therapy. I think overall, it's just great to see so many different drugs in development and hopefully approved soon. We think of targeted therapy as one of the major advances in lung cancer. The other major advance we've seen is immunotherapy. Do these intersect here, Enriqueta? Do we know anything about immunotherapy in HER2 mutant lung cancer?
Yeah. So the evidence of the use of immunotherapy in patients with non-small cell lung cancer with HER2 alterations remains scarce and is based on retrospective studies. We have the immunotarget experience published. This is an analysis of patients with oncogenic driver alterations treated with immunotherapy. These are retrospective analysis, but there are 30 patients with HER2 mutations included, and immunotherapy was associated with a response rate of 8% and a median progression-free survival of 2.5 months. So in general, what we have seen in retrospective studies is that the use of immunotherapy as a therapeutic strategy in patients with HER2 mutant non-small cell lung cancer is associated in general with poor outcomes.
Yeah, immunotherapy best used in other settings. Now, we want to steer patients more towards targeted therapies, and we have drugs available now, but we can only consider these strategies in HER2 mutant lung cancer if we properly identify HER2 mutant lung cancer. So for that, we need biomarker testing. Enriqueta, in Spain now, is everyone testing patients with lung cancer for HER2 mutations?
Yeah, so this is something that we are discussing a lot in Spain. We are now pushing for NGS analysis for patients with non-squamous histology. In fact, the majority of guidelines, including the ESMO guidelines, recommends a tumor or even a liquid biopsy analysis for patients with advanced non-squamous cell carcinoma to perform NGS, to enable the delivery of personalized medicine. So I think there is an increasing number of patients with stage 4 and non-squamous cell carcinoma tested using NGS technologies in Spain. And yeah, I think there is very nice data, and in my opinion, HER2 mutation should be analyzed and should be considered a standard biomarker for patients with stage 4 lung adenocarcinoma.
Yeah, I completely agree. And testing rates can always be better, but we saw some data at ASCO 2021 from Dr. Robert L., the My Lung Consortium, that looked at a US-based group. And a little embarrassing to sort of see how we're performing now. If we look at older alterations like EGFR, ALK, BRAF, ROS1, and PDL1, that 5 target set, we only test all of those in less than half of patients with non-squamous lung cancer. And so we can imagine that with HER2, RET, these other alterations, it's going to be much, much worse. So really, we are at the time when we need to be testing. You mentioned liquid biopsy. Is this something that can reliably detect HER2 mutations?
Yeah, it's that we try to perform first the NGS in biopsy. But if we find the results in liquid biopsy, I consider reliable. So yeah, I think it's something. And liquid biopsy has also some kind of advantages. The turnaround time is shorter when compared to tumor biopsy, and I think it's something that is probably complementary. So yeah, tumor biopsy probably is the standard of care, but liquid biopsy is also important for patients with lung cancer.
Okay, do you predict that we will see these HER2 targeted agents in the first line setting soon?
I think this is a very important point. It's true that with trastuzumab deruxtecan, we have seen a response rate of 55%, and as you mentioned, median duration of response 9 months, median PFS 8 months in a group of patients heavily pretreated. So yeah, I would be really interested to know this agent and the performing of this agent in the first line setting of patients with HER2 mutations.
Yeah. So, to me, it's clear that HER2 is an important and relevant target in lung cancer. These are cancers that behave differently. They don't respond in the same way to immunotherapy, which is important. And we have emerging targeted agents. hopefully approved and integrated into our treatment strategies pretty soon. All of this is still in the early stages. We're going to focus on moving these earlier, developing biomarkers a little bit better, learn about resistance, how to overcome, how to prevent it. We don't have time to get into all of that. I do want to be conscious of the hour. And so, Enriqueta, I want to thank you for your work in the field, always such a wealth of knowledge and experience. Thank you for taking the time to bring us up to speed and for a great discussion.
Thank you. Thank you, Stephen.
And to the listeners, thank you for participating in this activity. Please continue on to answer the questions that follow and complete the evaluation.